For joining the Systems for Action Research in Progress webinar. My name is Chris Lido and I'm Deputy Director at Systems for Action. S4A is a national research program of the Robert Wood Johnson Foundation housed at the Colorado School of Public Health. We support studies examining multi-sector collaboration across medical, social, and public health systems with the goal of improving population health and advancing health equity. Today, we're joined by an S4A research team based at Georgia State University, examining whether subsidizing transportation options can slow diabetes progression, and will walk us through the progress of their study. This research team has been with us since 2019. So we'll start off with a presentation from Drs. Faley and Chris Wozokowski, based at Georgia State University, with commentary from Katie Mooney at Grady Health System. If you all have questions for our investigators, please enter them in the Q&A box, and we will have time for questions at the end. But first, I'll introduce our presenters. Dr. Lee is an assistant professor in the Urban Studies Institute. Her work explores how individuals and markets react to and interact with policy. She's interested broadly in contemporary urban issues related to housing, transportation, segregation, inequality, public health, and the social impacts of emerging technologies. Dr. Wozokowski is a visiting assistant professor in the Department of Public Management and Policy and affiliate faculty with the Urban Studies Institute at Georgia State University. Chris is an urban policy scholar with research interests related to the interaction of society with the evolving urban environment, and his current research agenda is focused on the effects of transportation systems on neighborhood change, particularly micromobility and disaster recovery. Katie Mooney will be providing commentary today. She works in Grady Health System's Planning and Population Health Department, where she serves as Grady's first community benefit manager. And we'll have additional commentary from Renee Ogun, Marissa Felico, and Kara Sukerman. Apologies if I butchered those names. And with that, I will pass along to our presenters.
Yes, so hello everybody. I would like first to extend thanks to the Robert Wood Johnson Foundation for allowing us to continue this research and providing us with the funds to be able to execute it. So I'm going to start off with a bit of a background on our research. And so the first thing to note is that we know there are significant health disparities by socioeconomic class across the country. Here in Atlanta, this is a particularly acute problem. If you notice the panel on the left, we have a significant disparity spatially between neighborhoods located in the north part of Atlanta and neighborhoods located in the south and west part of Atlanta, which are high minority populations, as well as low-income populations in the south part of the city. And so we see significant disparities in the life expectancy, as much as 10 years. So we have two areas in Atlanta that are often compared, one to the north of the city, which is called Buckhead, which is an affluent, primarily white area of the city, as opposed to Bankhead, which is over on the left side of the panel in Western Atlanta. So the names sound similar, but the disparity you can see is very significant in terms of life expectancy. And sorry, I'm having trouble moving the. Okay, there we go.
Oh, sorry, it seems like I actually had the control.
Oh, you do? Okay. Okay. So the problems that we can identify as far as transportation as a determinant of health are tied to a few things. One is certainly access to medical care, access to healthy food, access to other essential services, and then social support and assistance for independent living, particularly for older folks. So we understand that mobility is very important in making these things happen, and it's partially responsible for the inequities that we see in terms of the life expectancy that I showed in the previous slide across Atlanta. So we know that transportation inequalities could shape these outcomes, as well as the behavior and lifestyles, which also contribute to these health disparities. Faye, can you switch the slide?
I think I no longer have control. Sorry.
Hi, Chris. So it says that you, there you go. Now you should have control.
It's still not letting me switch. Oops, there seems to be some delay. Okay, sorry. So what do we know about this? Transportation barriers can hinder healthcare utilization. The key here is there are several studies that found this, but the key is that most of these studies, they don't look at health outcomes. They specifically look at whether adding certain transportation options allows people to get to appointments. So the way this has typically been done is there an increase in the number of appointments as an outcome measure? Do we decrease the time that it takes to get to a hospital? Something like that. But the limitation is that there's very little evidence on actual health outcome measures, which is something that we try to get around to in this study, as Faye will discuss momentarily. Lack of transportation for low-income households, access to healthy food. So this is a lot of research on food deserts across the country, as well as in Atlanta. So we know that because of the lack of transportation access, there are areas within urban areas, particularly where people don't have access to healthy food, which could have negative health outcomes. We also find that across the country, public transit services can be absent in neighborhoods in need. My own recent research focused on Atlanta has found that public transportation access to employment and population centers is significantly higher in the higher income areas of the city relative to the areas in need, the lower income and minority areas. Also with transit access, there's limited access for the mobility of senior and chronically ill individuals. So these people have trouble getting around, getting to food, getting to healthcare. But there's very little evidence in how adding potential transportation options and reducing the barriers is going to help enhance mobility and in turn affect health outcomes of people. So our research objectives are to test the causal linkage between transportation barriers and the physical and mental health of the populations, compare alternative solutions to enhance mobility. So we look at different options for transportation that people can utilize, provide them, and see if there is an enhancement in how they're able to get around. And then we want to examine the gaps between different transportation services, particularly for those low-income, chronically ill individuals, where we can actually test their health outcomes. So in order to do this, we put together a partnership of stakeholders who have an interest in these outcomes. So obviously, the Metropolitan Atlanta Rapid Transit Authority is a partner. They have an interest in moving people around Atlanta, and one of their stakeholder groups are low-income individuals who are predominant users of public transportation. Atlanta Regional Commission is the planning unit for the city of Atlanta. A few other food banks that are interested, but our primary partner is the Grady Health System, which is conducting a food as medicine program, which is our main partner in this study. Katie, would you mind sharing a few words about food as medicine program?
Sure. Thank you, Chris. The Food as Medicine program is a partnership between Grady Health System, the Atlanta Community Food Bank, and Open Hand Atlanta. The food bank is our local food bank that serves the Atlanta region, and Open Hand is a provider of medically tailored meals. They work to deliver meals to individuals who have chronic diseases or who are unable to prepare meals for themselves at home. And so together we're working with those partners to address both food insecurity and chronic disease. Many of our priorities and community benefit, as well as population health, are diet-related chronic conditions like diabetes, hypertension, chronic heart failure. And we know that food is so critical to helping those patients control and manage their condition, but we estimate that about 50% of our patients are food insecure. So through this partnership, we are able to provide fresh produce and some other healthy, shelf-stable foods to our patients through a food pharmacy. And this is really a program to help them manage their chronic condition. And we pair the food along with cooking education and nutrition education. So it's a comprehensive program, and the food pharmacy is our main project, but we also work in some of our neighborhood health centers to distribute produce to patients. We have an inpatient food prescription program, and we also do some work with employees, since we know many of them are struggling with the same chronic condition. So it's a broad partnership where we're working really across Grady and trying to improve access to healthy foods for all of our patients, employees, and the greater community.
Thank you, Katie.
Chris.
Yeah. So as Katie mentioned, Grady Health System is serving a large population of the low income and minority, especially African American community in Atlanta. This is a map showing the distribution of Grady patients. And if you remember the first slide where Chris talked about the segregation in Metro Atlanta, especially the north, south, and west divide, and you see the darker areas where there are zip codes with the most Grady patients. These are mostly in the west side and the south side of the city, where is a large population of low income and African American people. And a lot of these areas are also marked by the red dots, which indicates census tracts with high social vulnerability by a CDC social vulnerability index. So these are the top 20% most vulnerable census tracts in Georgia. And about 60% of these patients are uninsured or underinsured, and high proportion of food insecure patients also related to chronic health conditions such as diabetes. Can we go to the next slide, please? Thank you. So a lot of these social vulnerability that these patients face, like homelessness, poor housing quality, overcrowding, and lack of transportation access. As you see in this map, even though Atlanta is known for being a pretty sprout city, but there's still a high proportion of households, especially in those poor neighborhoods on the west side and south side, without private vehicles. We also expect among the target patients of our study, a lot of senior and disabled populations, they might have limited mobility in terms of ability to drive. So many of these neighborhoods actually dependent on public transportation. As you also see the transportation lines in this map. The blue cross, so there are this major cross shows the two major transit lines by rail of MARTA, which is the public transportation agency in Atlanta. And the orange line shows a more extensive bus networks. So many of the low income patients, as far as we know, rely on the bus network. Next, please. And in order to, like Chris mentioned, we want to explore the causal linkage between these transportation barriers and health outcomes. So we designed the study with a randomized controlled trial, which lasts 12 months. And we want to assign people to 4 groups, initially 5 groups, but as I will introduce later, we had to change the study due to the COVID situation. And one of these will be a control group, and the other 3 will each feature an alternative mobility solution. We planned 5 waves of data collection, both at the start of when the patient joins our study, and then every 3 months afterwards, which is also the schedule that they're supposed to come back to visit their primary care physician, and also to renew their enrollment in food as medicine program. So we want to combine a survey on their behaviors, travel patterns, and health-related behaviors such as physical activities and self-reported health. We want to combine that with the health records that we obtained from Grady, which is their indicators such as blood sugar and BMI, blood pressure, which you want to track their health outcomes with. Other than these quantitative information, we also plan to collect qualitative data through open questions in the survey and also mobility counseling group. And the initial criteria for target participants, Grady patients with food insecurity and uncontrolled diabetes. Next, please. So the three alternative solutions we're testing with the three experimental groups include, the first group will get free public transit subsidies in the form of 10 free rides per month. We encourage them to use these rides on health-related trips, such as getting to their doctor appointment and food as medicine pickups, which is scheduled as twice a month. But we don't restrict their use, so they can basically use these rides for any purposes. The second group will get an equivalent amount of cash, which is $25 per month. If they use the money to buy MARTA rides, they can also afford 10 rides with $25. But again, we encourage them to use the money for health-related transportation, but we don't restrict the use. The third group is not getting any monetary support, but they, well, until the end of the study when we have a lump sum cash incentive for finishing the study, but they are receiving free mobility counseling. Next, please. The point of mobility counseling is try to improve the utilization of existing services and resources. Because as we see, the first two groups are receiving either free transportation or monetary support, but there are already a lot of other programs providing similar services. And we anticipate limited utilization of these resources, either because of lack of information or because of barriers in registration or reservation. So we want to use mobility counseling to help bridge people to these available services. And the counseling method that we're using is adapted from solution-focused therapy, which is utilized in fields like financial planning, marital therapy. And the basic idea is to help individuals frame their own goals. And with the help of a counselor, they can identify possible steps towards goals and then take actions. And here the actions could be anything like signing up for like a reduced fare public transportation program they are eligible for, or finding out where the nearest bus stop is, or finding other programs or signing up for other services that they could take advantage of. We also expect mobility counseling to help relieve anxiety related to their transportation barriers and financial situation and improve mental health. And we also expect to use this approach to collect more qualitative data on transportation barriers and how different systems can work better together to serve these populations. Next, please. This is a conceptual model. So we hypothesized that our mobility support in one of those three forms will work together with food as medicine, which, as Katie said, will provide free groceries, bi-weekly grocery pickups, as well as nutrition education. We hope together they will improve healthcare utilization in terms of improve primary care and routine care and reduce needs for emergency care. And they should enhance activities related to physical and mental well-being, like physical activities, social activities, and utilization of other social services. And they should have also a positive impact on people's dietary behavior, because these patients either with diabetes and as we are planning to expand to patients with hypertension, these health conditions very much dependent on lifestyle and dietary changes. So we're hoping that by making positive changes in their dietary and lifestyle, dietary behavior and lifestyles, we could help managing these, to help them manage their chronic health conditions. So eventually we will be tracking these improvements in their physical and mental health outcomes, both from the survey with self-reported health and also from Grady's records. Next, please. This flow chart shows the process of the study. As a patient come into the food pharmacy when they enroll in food as medicine, we will offer the opportunity to participate in our study. We expect to enroll 480 patients, which will be randomly assigned to for one of the 4 groups, which will have about 120 patients. And for a period of 12 months, we will provide transportation support every month, other than the control group. And we'll do the follow-up surveys every 3 months for a total of 5 waves. Next, please. So our study has been impacted significantly by the COVID-19 pandemic. Since March, we were under lockdown for a couple months, and the gradual easing up of restrictions till today, as you can imagine, the whole situation has dramatically changed a lot of people's mobility and accessibility needs. Most people significantly reduce out-of-home activities, and that certainly will reduce their needs for transportation. But as we consider our target patients, for this specific group, they still need to access routine care with both primary care, and in terms of their participation in food as medicine, they have to get to Grady at least twice a month to pick up the free food. So we still consider the mobility support that we offer an essential service for these patients. And also is the fact that these patients are less likely, if they're working, it's less likely that they will be able to work from home like a lot of us. They have the nature of their work, and also the fact of the digital divide in these communities make it harder for them to stay at home as much as the rest of us. So if they are essential workers, like workers in grocery stores, then they still have substantial transportation needs in order to get to work. There's been also anticipated reduction in utilization of healthcare and other services, so that will also change the way that our interventions can work and how we can better serve the needs of these patients. And is the fact that COVID-19 could be not only for our study, but a lot of studies collecting data during this period could be a huge confounding factor, because it has this profound effect on many of the outcomes that we're measuring, including health outcomes, mental health, both from potentially direct exposure to COVID, and also even if it's just from social isolation or from the economic outcomes from the pandemic, they could all affect the mental and physical health outcomes, as well as behavior that we are observing. And another impact has been on the availability of facility and resources, including the effect on Grady, a delayed opening of the food pharmacy, and also Georgia State University had been closed for most part of spring and summer, and that affected our ability of recruiting and working with graduate research assistants. We also had to change the protocol to make sure that we minimize the risk for both human subjects and our research staff. Next, please. So we made some significant adjustments to the initially planned study, which we first reported last year. From our initially proposed 4 alternative mobility solutions, now we have 3. We had to remove bike share as one of the research arms. This was initially due to the concern with our patients who are all high-risk individuals with underlying health conditions. There's a concern of encouraging them to ride in close quarters with, say, Lyft drivers. But then it was also necessitated by the fact that there was a sharp hike in Uber and Lyft fares because they had to cancel the share rides. For public transit, MARTA, the public transit system in Atlanta, has experienced some drastic changes during the COVID lockdown. they first suspended bus fare collection on buses, and they also cut a large proportion of the bus routes. And this affected many of the vulnerable communities, the majority communities that lost their bus connection. So shortly before our study started, shortly before we started recruiting patients in September, the bus fare collection resumed. So that made our proposed transportation solution more relevant, because now, again, the cost became a factor again for the transit riders. But there is certainly the concern of both these suspended bus routes, and also the concern of being exposed to COVID by riding public transit. So we had to incorporate these potential concerns and obstacles into our mobility counseling as well. We anticipated questions regarding these concerns of COVID transmission, also increased difficulties in riding transit or utilizing other services during this period. We had to include in our data collection effort additional questions regarding pre-COVID behavior, so we can make comparison with the current situation and what the lifestyles or behaviors were like before COVID. So we can hopefully tease out the potential impact of COVID and minimize the confounding factor. We also plan to ask people about their anticipated post-COVID behavior at the end of the study, if COVID is still a concern at that time, which we hope it's not. So we can then again compare how people expect to behave when COVID is no longer a concern. We have to switch the platform of data collection, but mostly for our surveys, from using a tablet at the food pharmacy to mostly over the phone. And COVID has also led to a delay in our time frame, and we expect it to need extension in the experiment period. So far, we have been recruiting patients for about 2 months, and the recruitment has been a lot slower than what we initially expected because of both the reduced utilization of healthcare. People are reluctant to go to the hospital. So we're planning also a plan of Subsidized medicine to extend recruitment eligibility from currently uncontrolled diabetes to also include stage 2 hypertension, which is also a chronic health condition that's dependent on diet and lifestyle. Next, please. So this shows our revised timeline. As you can see, we experienced a delay due to COVID from March to September this year. And we started recruiting patients in mid-September. So it's about 2 months now. And we have 44 participants, I think. And we conducted some very preliminary analysis based on the baseline survey for 35 of them. Next, please. And this shows a distribution of where these patients live. This is, a very small number of the participants, but it seems representative. If you remember the divide of neighborhoods in Atlanta, you see most of these patients are from the south side and the west side of the city. Next, please. I'm gonna get to Marissa, who conducted these preliminary analysis to introduce what we have seen from these 35 surveys so far.
Hi, everyone. I'm Marissa. I created some of the graphs you'll be seeing today. So first thing we wanted to find out were, do our respondents have access to cars? As you can see, a majority of our respondents do not. As everyone was saying earlier, we are generally working with people in lower income minority communities. So a lot of these people do not have access to a car. The next question we wanted to understand, how often did you leave your home in the past month? So this is currently with COVID going on. And it still seems like, despite COVID, People are still leaving their home on a daily or almost daily basis. You have people leaving a few times a week as well. But generally, people are still getting out of their homes as needed, even in the pandemic. So next, we have our preliminary analysis, and all of this analysis is based off of about 35 respondents right now. This is very early in our study, but the red bars are going to be currently right now in COVID times, and the blue bars are going to be pre-COVID, prior to around March, basically. So the first graph, we have the mode of transportation medical appointments. So in this question, we were basically asking, how did you get to this certain location, whether it be a medical appointment, schoolwork, a service, or social. So we wanted to understand how people were getting to where they needed to go. So for medical appointments, it seems as though a lot of our respondents, even during COVID and before it, they're using MARTA quite often, which makes sense, right? A lot of these people tend not to have cars. We have some other really interesting ways that people got to where they needed to go. I think someone else will be touching on that. And prior to the pandemic, Uber and Lyft were also used more than they are, they were used more for medical appointments as opposed to school and work. And the school and work graph is what I personally found really interesting, because you can see here prior to the pandemic, people were using more varied methods of transportation to get to where they needed to go. And I do want to reiterate, some of our respondents are unable to work due to disability, retirement, or their own various reasons. So this is a part of our data as well. But even in the pandemic versus prior to it, you can see there's a big discrepancy in how people are getting to school and work. Some of this could also possibly be because we are in a pandemic. And as Dr. Fay was saying earlier, not all of our respondents have the ability to work from home as we do here in this presentation. But this is going to be the biggest change that we've had so far. It's methods of transportation in school and work. And I found that to be a really interesting point as I was doing my analysis. MARTA has still remained pretty high though, and it's actually increased in usage, which is interesting to note as well. Next, you look at services. People are still really using MARTA. That's a big method of transportation, even currently, especially currently. And finally, you have social, how people got to their social events, whether it be hanging out at a park or hanging out with friends, whatever they're doing socially. And this is the graph that, too much like the medical appointments, has remained pretty consistent. The biggest change you notice is more people are hanging out socially from home in the pandemic, which makes a bit more sense. And then down here, so we also collected their monthly expenses. We asked people to, on average, give us how much they spend on transportation, housing, and grocery. So the biggest change you're going to notice is actually in the housing. I noticed that overall, people were spending, prior to the pandemic, around $600, $650 a month on housing expenses, whereas now it's the median has seemed to jump up to around $800. So that was really interesting to me. That is really the largest median discrepancy jump we have. In transportation, it's stayed around 50 pre-pandemic and during the pandemic, and grocery expenses, the median has stayed around 200 pre-pandemic and in the pandemic. So I thought it was really interesting that housing has increased. Don't necessarily know why, but that's been the biggest change in terms of average costs per month.
So I guess I want to add that seeing the average or median transportation expenses among our participants, you can see it's a very low budget, around $50. So the cash subsidy that we provide, $25 a month, should make a difference if they use it for transportation. And regarding the housing expenses, and this is kind of speculative, but maybe Kara can share some insight on that. Kara is our research assistant doing some of the telephone surveys. So I noticed something is about half or maybe 30 to 50% of our participants don't really have a stable residential location, like they choose living with family or relative or friends. So I wonder if that's a situation that was worsened by COVID, that they had to maybe search for more expensive housing options.
Can you hear me?
Yes.
I think that is really interesting. Just anecdotally, since the sample is small, people haven't really been talking about housing expenses going up in particular since the pandemic. In fact, I actually haven't had anybody say that the pandemic influenced whether or not they moved, whether or not they answered the question when we ask if they've moved since the pandemic. But I definitely think this is really interesting. They've definitely talked more about going, grocery shopping less or leaving the house less, but I haven't really noticed a reason why this would be the case, but that's really interesting. I'm sorry I can't shed more light on that.
Yeah, another thing is that we actually include utility bills in housing expenses. So this is something that might happen to people who work from home a lot, that they might see as like in their electricity bills, but I don't know how true it is for our patients. But again, these results are very early, given the small number of surveys that we have so far. Just found some potentially interesting points to share. So I guess that's the most of our presentation. As Kara or Renee, if you want to share some more about the work on the field, any other stories as you work with the patients.
I can go first. This is Kara. Hi, everyone. It's been a really interesting experience. It's interesting. A lot of people, they're not necessarily super excited to take the survey, but then often when the survey is over, they are also not ready to hang up, and they share a lot about how their life has been impacted by the pandemic and just their life in general. A lot of them have really inspiring goals of getting healthier and reducing their medication use and just increasing their health. I hear that a lot, but it's, again, something that they often tell me when the survey's over. I think the most memorable interview I've had was somebody who was serving a very long prison sentence, but she was released from prison due to the pandemic, and she was incarcerated for 37 years. And it was really interesting to hear how she told me she lost over 100 pounds while she was incarcerated, and how now she's focused on continuing to get healthy and integrate into life outside. And she was really, really inspiring. But everyone has been, like I said, really happy to share their stories, and I think happy that people want to listen, and they all seem, I think they'll benefit from participating.
Thank you, Kara and Marissa. I guess we can, this is the commentary part, so we can have Katie and Renee giving the commentary.
Hi again, this is Katie. Thank you all so much for this presentation. We are really excited and pleased to be working with Georgia State. Food, transportation, and housing are our priorities around social determinants of health for our patients. And so being able to offer this transportation support in the form of a controlled trial is extremely valuable to Grady, and we are really looking forward to seeing some of these results. This already is really helpful information to be collecting about kind of our patients' experience. The pandemic is affecting every single part of everyone's life, so it's really helpful even just having some of these anecdotal stories of our patients to help us really tailor this work to our patients' needs and continue to work towards meeting those needs in meaningful, effective ways. And it has been, yeah, wonderful working with this team at Georgia State. We've been great partners, and even with all of the delays, COVID and construction, they've been very patient with us. So we are excited to finally have this off the ground. If Renee is on, I know she's in the food pharmacy with patients, so she may have gotten pulled away. But Renee, I'd love to hear some more. If you could give us maybe the latest on how many patients are enrolled in the food prescription program, how many have chosen to participate in this study, and then what your experience has been introducing the study and communicating with patients about the transportation support. Renee, are you on? Okay. She may have gotten pulled away, but the latest numbers that I am aware of, I think they might be a little higher than this, but overall in the food prescription program, we have enrolled about 170 patients,
71.
I believe.
I'm here, Kate.
There you are. Hey, okay. Awesome.
I'm sorry, I couldn't find it on mute. Yeah, we have about 171. That, of course, that number will decrease probably next month, because that's when we have our re-enrollment of our for the second episode, because all the participants have not been participating in all the requirements that they need to participate in to be able to re-enroll again for another episode. I believe we have about 44, I think, GSU, and I'm still working on recruiting patients weekly. For me, it's like when I originally introduced the study to patients, I tell them that, you know, Georgia State is doing a study based on transportation, and they're trying to see how transportation affects healthcare. Then I tell them that, you know, they'll be placed in one of 4 groups randomly. Some patients like patients who take MARTA, they might get excited and, yeah, I hope I get a MARTA card. Others who don't take MARTA will be excited saying, hey, I hope I get the check or whatever. And it's exciting to see patients who was hoping for what they wanted, got what they wanted. So that's a good experience, because, you know, especially patients who ride MARTA, the ones that actually open an envelope and see that they actually get a MARTA card, they're like, yeah, you know, this is really gonna affect how I go here or there or whatever the case is. So I second that notion with Katie. The team that we're working with at Georgia State is awesome and patient. So I appreciate everyone's help, the research assistants with calling these patients, because I know it can be difficult sometimes. The patients are hard to reach. So I appreciate everyone, and I'll just continue doing what I do to increase the participants number.
And I would just add, you know, how important the transportation support is to our food as medicine program. Normally these folks with uncontrolled diabetes or uncontrolled hypertension would be coming to Grady once a quarter to see their primary care physician. Of course, they may come back for other services as well, but in food as medicine, in addition to those quarterly primary care visits, we're asking them to pick up food twice a month, come to a cooking class each quarter, and come to a nutrition visit, although nutrition visits can be virtual right now. But that's a lot more trips to Grady than they normally would need to take. And so, you know, we in our planning knew that transportation support would be critical. So having this partnership with Georgia State is extremely valuable. And the support around research is also important. Really, what we're doing around food as medicine is something that we want to study and evaluate closely and help build the evidence for these type of programs for other healthcare systems and for insurance reimbursement. Medicare is starting to do some medically tailored meals in certain populations, but cooking classes and food prescriptions are not a covered service at this point. So we're hoping to be a part of that evidence base to build, because if you think about it, food is a lot cheaper than medications or cheaper than hospital stays. So we're really excited about this partnership and hope that with the support we can help increase and grow food as medicine programs across the country.
Thank you, Katie and Renee. I think we can move to answer some questions.
Yeah, let's do that. I hope everyone can join me in thanking our presenters today for sharing their findings. Feel free to add questions to the Q&A or chat box. So far, we have received one question, and I'll direct this to Chris. What can the community sector do to support reimplementation and improvement of PPACA by President-elect Biden, with guidance from Dr. Fauci and others, etc.? It's kind of a broad question, but if you could riff on that a bit, that'd be appreciated.
Yeah, thanks, Chris. So yeah, that is a very broad question, and so again, our study is kind of micro focused on how does transit affect health, but then obviously from the research you want to draw some conclusions and some application to policy. So we do have a broad community sector support in our work. I mentioned MARTA, Grady, obviously, a few other groups that are interested in food delivery. So I think the community sector, the main thing that they can do, and this is kind of what we're trying to do as well, is work together. Again, when we think about systems for action, we're thinking about connecting different groups, different systems, make them work together to improve health. So I think this transfers also to what communities can do, right? Is no one advocacy group or community group can do everything, but where we see that there are opportunities to work together to solve common problems, I think that's the way to go. So for example, in our study, we have the Metropolitan Atlanta Rapid Transit Authority, whose main interest is moving people around the city. And then we have the Grady Health System, whose main interest is obviously improving the health of people, but they do have significant overlap in that their stakeholders are oftentimes the same people. And MARTA, for example, is very interested in addressing homelessness that affects their constituents, which those things obviously affect the health of their stakeholders. So kind of a long-winded answer here, because it is a broad question, but I think what community groups can do is look at other community groups, see where their interests overlap, see where their stakeholders share interests, and I think stemming from that, the things that emerge from those collaborations can then have an impact on broader policy, such as health policy that the new administration is going to try to bring in.
Thanks for that response, Chris. And we have a few other questions, unless others want to chime in as well.
I would just agree with that. I think the partnerships are really key. We know there are so many needs that our patients have outside of the four walls of the hospital, and as a health system, we want to think creatively about how we address those. But like Chris said, we're not a transportation provider. We're not a food service industry. so identifying those partners that have similar goals, and food as medicine and this study are perfect examples. So I think we need more of that across in our communities.
Great, great. So let's move into the next question. Did you base your study design on other efforts to link policy changes to health outcomes? And if so, can you describe some of those?
Yeah, so actually this study was kind of a development based on somewhat a pilot study or pilot program of Rice Wellness that also was a partnership between Grady and MARTA and some of other community partners. So in that program, they also use public transit free ride on MARTA for low-income patients. And they do observe an increase in, say, following up with doctor appointments. But in that study, we did adopt the RCT design of a control group to compare the improvement between people who are randomly assigned to a control group and experimental group. So part of the reason that we're adopting this design now is to base on those early observations and see how the changes are actually due to the availability of mobility solutions or either public transit or through the cash grant or through mobility counseling in our study, and to produce a more robust result for policy changes.
Yeah, just to kind of add to what Faye said, I mentioned this at the outset of my portion, but we have you know, sorry, I was going somewhere with this, lost my train of thought. So the key is that the previous studies were looking at just does public transit lead to more doctor's appointments? So are people keeping their doctor's appointments? Does public transit or other transit reduce the time that it takes to get to work? So our study is a bit of an evolution from that, in that we're actually looking to capture health outcomes. So it's not just, you know, are you going to the doctor more, but is your health actually improving? So the group of people, the participants that we're using, who are diabetics, diabetes tends to respond well and quickly to changes in health. We can measure blood pressure, we can measure blood sugar, and those things are very, very easy and quick to capture. So we did base this on a previous study, but we've kind of you know, taken the next step in not just looking at are people showing up, you know, at the hospital or at the doctor, medical clinic, but are we actually having an effect on health?
Thank you for those responses. Okay, so we've got a three-part question. So I think maybe Faye can take this first part, and I'll direct the rest of the question to Katie. So first part of the question, so there's an understanding that you know, food assistance can have a big impact on both stress and physical health. How is the impact of food as medicine separated from the impact from mobility supports?
That's a great question. So in our current design, all of our participants will be from participants of food as medicine, which means our control group and all three experimental groups will be receiving the same food support from food as medicine. So that is how we expect to, through the design, to, you know, keep the food part constant and compare what the difference the mobility solutions can make. In addition to that, it could be possible to compare food as medicine participants with those who are referred to food as medicine but didn't participate in the program. But because the fact that the program was administered and we rely on the food pharmacy to keep in touch with the patients, and we also consider our mobility support to be more useful and more tied to health because of their needs to participate in food as medicine. So we don't have a feasible way of recruiting outside of food as medicine. But as I said, through our experimental design, we should be able to identify the separate effects of the transportation support. Although there is also a potential way for food as medicine to evaluate their outcome from food assistance by comparing their patients with those patients who didn't choose to participate in food as medicine.
Thank you, Faye. And the second part of the question, anyone can answer it, but I think Katie, I'll direct it to you. Are the meals from food as medicine medically tailored? And what are the other ways that data is being taken for food as medicine?
Sure, thank you. So the food that patients are receiving as part of the food prescription is primarily fresh produce. So it is not prepared. It is a variety of fruits and vegetables from the Atlanta Community Food Bank, and that's the majority of what they get. And then they also get a small portion of healthy whole grains and plant-based proteins, so like brown rice or dried beans and peas. So we know we're not providing meals. We know it's not 100% of what their diet is, but we know that fresh produce can be either hard to access in certain neighborhoods or potentially more expensive depending on where you're shopping. So that's why we've chosen to provide that food for patients. And then I think we talked about a lot of the factors that we're evaluating, but in addition to those specific health outcomes, Grady will be looking at healthcare utilization. So are patients going back to their primary care doctor more than they did before they were a part of the program? Have their admissions or ED visits decreased? Are we saving money? Obviously, food as medicine is an investment, so we're hoping to show that if we provide this service on the front end, that we're saving money on admissions and ED visits, which a lot of these patients are on our financial assistance program. So Grady does bear the cost of a lot of that. And then some other interesting pieces that we're looking at are we're using the CDC's 4 quality of life questions, and we'll be asking those each quarter. We are also using the 6-question food insecurity module from USDA. So in addition, when they're referred in the clinic, just positive or negative for food insecurity, when they get to us in the food pharmacy, we're measuring their level of food insecurity or level of food security. And so we will be evaluating to see if that changes over time. And then the last thing that I would add, and because several people have mentioned mental health, we are looking at the depression screen as well. So the PQH2, I believe, is what we're currently looking at, and that is conducted in their clinic visits. So that will be evaluated pre and post as well.
Thank you for that thoughtful response. And also thank you, Drs. Lee and Wazokowski from Georgia State University. And thank you for commentary, Katie Mooney from Grady Health System. Let me give a few announcements on our way out of the door. If you would like to receive a certificate of completion for today's ResProg webinar, make sure to complete the survey at the end of the session. It should pop up automatically, but one will be emailed to you as well. And December 9th is our last research in progress of 2020. We'll be hearing from Dr. Yuha Bao from Cornell University, and she'll discuss financing coordinated medical and social services for patients with psychosis. Thank you everybody for joining us, and we look forward to you joining us again in December. Enjoy the rest of your day and have a good week.
Chris?
Thank you.